thank you all for giving me this opportunity to talk to you. And I know it is quite a challenge after lunch to get you interested in a subject like resource mobilization. So I hope, I will succeed in energizing you, getting your interest in this subject.
Well, Christoph, I said you're one of the best advocates. So
well, yes, but now I have a real challenge because I'm not asking you for money. I'm just asking you for your interest in where the money is coming from. But I think we can discuss a really exciting story, because what happened over the last decade has been absolutely unprecedented. The amount of money that has been mobilized for global health. And I want to go a little bit into the details, where is this money coming from? What does it take to mobilize this money? And also, what's the prospect for the future? And I know that many of you are engaged in implementing probably programs that receive financial support from PEPFAR, from the Global Fund, from Gavi, from other funders. And you might not necessarily think about, how do these organizations get the money? But there is a lot of work, sometimes also hard work, to convince politicians, congressional members here in the US and in parliaments around the world, so that they allocate the money that you very often will then have the responsibility to utilize in your countries and turn that into life-saving programs. So that's why I hope, you will see the link between what I have to say this afternoon and your own work in the countries. But I will also emphasize that we do need your support as well. Your kind of feedback from the countries is absolutely critical for us when we go out to talk to the politicians and to those who, in the end, make the decisions about the financial resources. So let me then go into the details where the money came from and what happened over the last couple of years. We have really seen an unprecedented increase in financing for global health. That is a graph from a publication last year in The Lancet that shows that between 1990 and 2007, the financial resources for global health increased from $5.5 billion to $21 billion. And I don't think we have ever seen certainly nothing like that in health. But I would also claim not in any other area of development. We haven't seen anything like that in education or, hygiene and sanitation or environmental protection or any other, important area. So something has happened here that is really quite outstanding. And there are a number of factors, and the US has certainly played a key role in this, because some of the largest allocations for international health have come from the US government, but also from the private sector, and particularly from the foundations. And obviously, the outstanding example here is the creation of the Bill and Melinda Gates Foundation in the year 2000, that also contributed enormously to the increase in resources to global health. But then also from a number of other countries, from the UK, Japan, Germany, France, Netherlands, and other countries, they all increased their allocation to international health. A very special event was the creation of PEPFAR in 2003. And you see here the allocation of PEPFAR, by far the largest bilateral program in health that has ever been established by any country in the world. And you're all probably very familiar with the impact of PEPFAR in the countries where you are working. Now, another question is then, this money for which health problems? So if you look at the slides, 14.5 billion of this money, out of the 45 billion in 2007 that was allocated overall, 5.1 billion went to AIDS, 0.7 billion for tuberculosis, 0.8 billion for malaria, and 0.9 billion for health sector support. So we've seen an overall increase, but certainly, the share of the increased money for AIDS was the largest. And then the question is now, why did all of this happen? And why so much money went into AIDS? And I think that is very important to understand the context also for advocacy, also when we look into the future later on. And we have to understand that something very special happened here. For the first time in history, we've seen a solidarity movement between people living with a certain disease, in this case HIV/AIDS, in the north, in the wealthy countries, and people living with the same disease in the south. It was a particular moment when people living in rich countries suffering from HIV/AIDS, knowing that their life depended on the availability of money so that they could buy the drugs, that this was the same disease that millions of people were dying from in the south. And then to say, we demand the same right to life, the same right to access to this life-saving medication that we have, and we want that to be available worldwide. We really have to kind of contemplate for a minute what that meant, because it has never happened with any other disease, nor with any other health problem or any other problem, I would say. So there's something very special. And so the best expression for me is what Justice Edwin Cameron said, at the AIDS conference in Durban 2000, which for me still is a kind of defining moment in the history of not only the fight against HIV/AIDS, but also in the mobilization of political support for health in general. So he said at this conference in Durban, I stand before you because I am able to purchase health. I'm here because I can pay for life itself. To me, this seems a shocking and monstrous inequity that simply because of relative affluence, I should be living when others have died. Our overriding and immediate commitment should be to find ways to make accessible for the poor what is within reach of the affluent. This sentence summarizes the whole movement that has been behind this mobilization of resources. And it has been repeated by many other leaders in this field, and it has reached then the influential people, the politicians, those who make the financial decisions. But it started with a statement like that. There is, of course, a question, why only in AIDS? And when will we see a similar movement also for other health problems? Because you could easily see that also other people, let's say, a woman who gives birth here in a hospital in New Haven and has a cesarean section and owes her life and the life of her baby to the availability of wonderful facilities in maternal care. Why should that not be available in all countries around the world so that, we can reduce maternal mortality and other problems? We haven't seen this kind of movement yet, but I do believe that this, is a promise for the future that, might also materialize one day. But it clearly happened with AIDS. Let me go into a few other explanations why there was what I believe has been a paradigm shift in the whole thinking and understanding of global health. The first is the understanding of health as a human right. And this is not a new idea at all. It has been in UN documents, in the Charter of Human Rights. It has been expressed many times, but I believe it has never been taken really seriously. If you read what the UN Charter says, everyone has the right to a standard of living adequate for the health and well-being of himself and of his family. And there is an international obligation to make this happen. But it was kind of considered a soft right, in a sense, a social right, not a kind of, civil right, and therefore not to be implemented by countries around the world. And I think the AIDS solidarity movement has contributed to put, health as a human right back on the political agenda, and therefore had also contributed to the impact that we've seen before. There's also another argument that is very important, and actually I'm very pleased that Gorik has joined us, because Gorik has promoted that idea that I've very much supported, the question of sustainability as self-sufficiency. And to move from sustainability as self-sufficiency into sustainable global solidarity. I've worked myself as a medical doctor for some years in Tanzania, in East Africa, and I think, I understand very much the situations, in which you work. And also when I was working there, when I was implementing primary health care, it was with the understanding that, yes, you can support that externally, but it should be self-sufficient. Primary health care was something that, communities could maintain themselves. It was not something that required international solidarity as a right to kind of support these services. But when we entered into the era of providing antiretroviral treatment globally, it was clear that this was not just a kind of short-term measure, that we give it to people for 1 or 2 years, but then, you know, people or communities or governments should become self-sufficient. But it was with the full understanding that this would have to be maintained long-term. We are talking about lifelong treatment here, and not about something, you know, that we can phase out. And I'm not talking here about middle-income countries that might well be in a position to do that over time, but a lot of countries will require this international solidarity for a long time, and I do think they have the right to receive this solidarity. And also there is a kind of trend from moving from development aid to a kind of system of global social security. We have observed a gradual shift from development aid to a still rudimentary but emerging form of a global social security system. That is my deep conviction, and I think that's what we have to work on in a globalized world. We should accept the argument that risks need to be shared more widely and that a person should not be refused the right to education, food, water, or healthcare just because he or she was born in a country that cannot afford a minimum of social protection. So these paradigm shifts in the understanding of global health and the powerful advocacy spearheaded by AIDS activists from around the world had to converge to result in the increased resource allocation we've seen in recent years. And then as a result of that movement, we got this political support at the highest possible level. And you know, the person who probably did most to promote that was then Secretary General of the United Nations, Kofi Annan. And he brought together many leaders, political leaders, NGO leaders, private sector, and others. He organized the UN General Assembly special session on HIV/AIDS, the first time that the General Assembly ever discussed, you know, a health problem at that level. They issued a declaration supported by all the member states of the UN, and part of that declaration was the call for what Kofi Annan called a war chest for the fight against HIV/AIDS. And that was the beginning of the Global Fund that was then created shortly after that. Right after this UN General Assembly in June 2001, there was the G8 summit in Genoa that provided the first money for the Global Fund, and Kofi Annan pushed everybody very hard so that the Global Fund could be established in January 2002, just 6 months after this UN General Assembly. So if you now look at, you know, what happened with the resources over time, you see a very steep increase from the early years just in the response to HIV/AIDS, and you see the kind of very important marks here: creation of the Gates Foundation, the UN General Assembly, then the creation of the Global Fund, PEPFAR, and so on. And then we've seen an exponential growth in the resources over the last few years. So, but I also want to emphasize that this why AIDS played a very important role in this whole movement. The resources that have been mobilized have not been restricted to HIV/AIDS at all. And let me just give you a few examples and start with vaccine and immunizations. There is the Global Alliance for Vaccine and Immunizations, Gavi, that has been created in 2000, that is supporting many countries around the world, providing access to the immunizations for children, the standard immunizations that have been used for a long time, but also helping countries introduce new vaccines that so far had been out of reach for many countries, like hepatitis B. And currently Gavi is involved in the rollout of new vaccines, rotavirus vaccines and pneumococcal vaccines that are available, but currently still too expensive for many countries around the world. And that's exactly what I described as the paradigm shift, that while we would have accepted that 20 years ago, that here you have these vaccines, you use them in the US, you use them in Europe, but you don't make them available for the millions of children dying from diarrhea and from pneumonia, this has changed. And we do now know that we have to make those resources available so that people access, in this case, vaccines, particularly affecting childhood diseases. And another very important discussion now is around maternal health. What many regarded as a kind of neglected health problem, and I would fully agree with that, although resources for maternal health has also increased over the last few years, and there are data to show that in the year 2003, $2.1 billion were available for maternal health, and in 2007, $4.1 billion. So it's not that no resources have gone into that, and that's why I also always argue that we don't take money away from one cause to the other. We try to mobilize resources for health in general, but certainly it has not been the same increase that we've seen for HIV/AIDS. But particularly this year, we've seen an unprecedented political mobilization around maternal and child health. And most prominently of that is the initiative started by the G8 presidency of Canada. And while the G8 summit will only happen tomorrow, I have here on the screen for you what I've received as the draft of the final communique, and I trust that you will not quote me today, because I'm sure it is under embargo today, but I hope you will see that, tomorrow or the day after. But it is no secret that the Canadian government has pushed very hard for this initiative, and this is what we expect to be in the final document, where they say progress towards MDG 5, improving maternal health, has been unacceptably slow. And consequently, we, the leaders of the G8, working with other partners in developing countries, launched today the Muskoka Initiative, a comprehensive and integrated approach to contribute to progress towards MDG 4 and 5 that will significantly reduce the number of maternal, newborn, and under 5 child deaths in developing countries. And I guess that many of you will appreciate this initiative, because I guess that many of you will be working on these issues. And in line with the G8 presidency, also the current UN Secretary General Ban Ki-moon has launched an initiative on maternal and child health. He is working on a joint action plan that he will launch at the Millennium Summit of all the heads of state meeting in September this year in New York. And finally, also the African Union Summit in July in Kampala will focus on maternal and child health. And the African Union has been working more than a year on that program. So just to show you, sometimes how you can create a momentum of, political support, political will. But again, it's related to health, and that is very important. It's, it's expanding, it's moving also from AIDS, TB, malaria to other areas, but health has been, and I guess will still be, very high on the political agenda at meetings like the UN Assembly, like the G8, and others. So now I turn to the organization I work for, the Global Fund to Fight AIDS, Tuberculosis, and Malaria. But not only because I obviously love that organization, but also because I wanted to use the Global Fund as a kind of example. How you can mobilize resources and what is required for successful advocacy. Because one of the key areas that you need is you have to demonstrate that the instrument you are promoting is innovative and is producing results. Which means advocacy can only be successful if you have a product, if you like, that you can really sell to politicians. It's not just a PR activity. It's not, and thank you, Mike, for your very kind words, that I can be persuasive in US Congress, but I wouldn't be able to be persuasive if the Global Fund wasn't working. I wouldn't be able to persuade anybody to give money to an organization, to an instrument that was dysfunctional, that was not demonstrating results. It's impossible. So that's my first very important statement. Whatever we are advocating for, you need to have an instrument, a channel in a sense, that you can present to politicians and then convince them. And that, by the way, will be the same challenge now as we are moving into maternal and child health and increasing the advocacy for that. Also then, you will need a kind of channel that you can present to politicians. So, what are and this is then a slide that shows the increase of the resources of the Global Fund since its creation in 2001. I talked about the UN General Assembly, and you see that there has been a kind of constant increase in the resources that donors, both from the public and the private sector, made available to the Global Fund to fight AIDS, tuberculosis, and malaria. We started in the early days with about $800, $900 million per year, and then we moved, to 2, 3, and now this year, probably the income of the Global Fund will be around $3.6 billion. So why is that? And let me mention a couple of key, let's say, aspects of the Global Fund that have enabled us to go around the world, talking to governments, talking to private companies, to persuade them that this is an instrument they can invest in. The first of those is what we call performance-based funding. And some of you might be actually quite familiar with the Global Fund model if you're working, with Global Fund grants. Then you know that the Global Fund has a very strict system, in a sense, to, approve grants that have very clear targets, very clear indicators that are measurable, that can be validated, and that the disbursement then follows the actual performance of the grants and the achievements of results. And I am aware that sometimes that might also be burdensome for many of the countries we are working in, but it is a kind of precondition, because if we wouldn't have those results, if we were not able to show and demonstrate measurable results, we would never be able to mobilize the kind of resources that we have been able to mobilize. Another aspect is what we call value for money. We always have to demonstrate to the donors that what we do is not only effective, achieving results, but also efficient, that we are achieving those results with the least resources possible. And I can tell you, in this current economic climate, that is probably the question I get most. What do you pay for the services? What do you pay for the drugs? Can you reduce the cost for the drugs? Can you achieve more with the same amount of money? And that is not always easy. And I know that also often puts pressure on you, maybe in the implementation of the programs. But it's one of the key questions that we get, that we can demonstrate this efficiency. And finally, also the aspect of accountability and transparency. That the grants are fully accountable, that we are transparent, that we put all our disbursements on the website, that we have an independent inspector general who is reporting back to our board. It's all meant to increase the confidence of the donors in this instrument, which is absolutely essential for the advocacy then to work. And the last aspect of that is extremely important for the Global Fund is the governance structure. And the Global Fund has a very innovative governance structure because on our board you have the representatives of the public sector, the governments, both from the donor governments and from the implementing countries, the private sector, civil society, and you have the technical partners like WHO, UNAIDS, and the World Bank sitting on our board. Now, having all of these, representatives on the board, that is not so innovative. But what is innovative is the decision-making structure of the Global Fund, because every board representative has the same vote. Whether you're a donor, whether you're an NGO, whether you're an NGO coming from Africa, or whether you are the representative of Japan, whether you are the representative of the private sector or of the foundations, you have one vote. There are 20 members, and they are divided into two blocks, the donors and the implementers, and you need a 2/3 majority to make any decision. That means no group can dominate the other. And I would claim that this is the only multi-billion-dollar organization in the world where donors, commit more than $3.5 billion every year, but grant the same decision-making power to those who do not contribute with money, but who implement this money and turn this money into results, whether you're a representative of a government or of a civil society. That's the decision-making structure of the Global Fund, and it has been absolutely critical also for the advocacy efforts of the fund. Because, and I will come to that in a minute, the very important in our advocacy has been the support, particularly from civil society. both from the north and from the south. And this advocacy, this energy, this enthusiasm you get from civil society around the world, you only get because they feel the ownership. They say, this is our instrument. It might not be perfect. Nobody thinks the Global Fund is perfect. There are lots of things that we constantly have to review and to improve. But it is our instrument where we are part of the decision making. We can change it. We are working all the time to adapt the systems, to simplify at the moment. We are reviewing the whole architecture. So this kind of ownership then leads to effective advocacy. And finally, what is obviously very important is that you can then demonstrate real results, that we can go out to the donors and tell them what happens with the money. So currently, we have approved grants, more than 600 programs in 144 countries worth $19.2 billion. And that makes the Global Fund the major investor worldwide in AIDS, tuberculosis, and malaria. The donors so far have pledged about $22 billion, of which $16 billion have been paid in. And I will come to the distribution of the income in a minute. But more important is what this money then has translated into the concrete results in the fight against the 3 diseases. And we report those results very regularly, every 6 months. And we just got the latest results out in the end of June. Currently, the Global Fund is supporting 2.8 million people on antiretroviral treatment. 6 million people are receiving tuberculosis treatment, and we have helped countries to distribute 120 million impregnated mosquito nets. So those are then the results that we can really demonstrate and go back to the donors and report on. And this is not just in terms of the services, the drugs, the bed nets, but in the end it has to translate into reduced morbidity and reduced mortality. So you want to see in the end what kind of impact does this investment have. And this year in particular, as we have the review of the Millennium Development Goals, and as the Global Fund was created to help countries achieve the Millennium Development Goals, there will be particular scrutiny of where we are in terms of the achievement of the MDGs. This shows the numbers I just mentioned, but also the kind of increases that we see from year to year. So for example, on antiretroviral treatment, 22% more people on treatment compared to the year before. In terms of bed nets, even 39% more than in the year before. So that's the results we can demonstrate. But if we then look at what has happened with that in terms of impact, let's look at the 3 diseases. Malaria in 2002 was basically a neglected disease. There was very little funding available for malaria, and that was also my experience when I worked in Tanzania. I had basically no resources except for chloroquine and quinine and the most basic treatment, and there were no bed nets available in the villages, and that, I think, has really changed. And I hope that many of you have seen that in the countries where you work, and that we really see now a decrease in morbidity and mortality in countries, and I know in many countries it's now between 50 and 80% decrease for this disease. Similarly, TB in 2002 was basically a neglected disease, very little international funding available. Now we have, millions of people who've received DOTS treatment. We have improved diagnostics, case detection, but also cure rates. And basically for tuberculosis, we can probably go to the Millennium Summit in September and say we are on track to achieve the MDG on tuberculosis. You have the numbers here. There were very clear targets. The incidence rate was 220 in 2000, and the target for 2015 is 124, and we are currently at 164 new cases per 100,000. So that is exactly on track of where we should be to decrease tuberculosis incidence. And then on HIV/AIDS, 10 years ago, when this whole movement started, there was hardly anybody with access to antiretroviral treatment in Africa and in other developing countries except for Brazil. Now we have 5 million people on treatment, largely due to the support of PEPFAR and the Global Fund. But we've also seen, as you certainly know, a decrease in prevalence and infection rates in many countries, although going down slowly, and we have to redouble our efforts to combat this disease. So, this is the message that we will present to the MDG Summit. We also emphasize the interconnectedness of the MDGs, because there has been the argument that, yes, you've done quite a lot on AIDS, tuberculosis, and malaria, but you have not made progress on, for example, maternal and child health. And as I said before, I agree, more needs to be done in this area. But we also have to see that AIDS, tuberculosis, and malaria are still major causes of death for children and for women, particularly in Africa. And therefore, there has also been progress on that. And we now need to look at the health-related MDGs together as a kind of comprehensive program. So that's the kind of background, if you like, for the advocacy that I wanted to talk about, because only if you can demonstrate that, then you can really mobilize the political support. And this political support also includes the support of leaders from your countries. Without your ministers of health, without your presidents and prime ministers to speak up at the international meetings when they meet with the leaders from other countries, we would never get to the resources we need. One element that has been quite critical has been to mobilize some key influencers who have the direct access to people who finally make the budgetary decisions. And that has been critical in our advocacy effort, not just for the Global Fund, but for health overall, that we were able to mobilize people like Kofi Annan, like Bill Gates, like Bono, who then can talk to the heads of state who finally meet at the G8 summits and then make the decisions. We have for this year, as it is a very important year for the Global Fund, as we have our replenishment currently going on with the pledging conference in October, we've produced a little video where we collected the voices of these people, and I wanted to show you a very short kind of video clip with these key advocates of the Global Fund to give you an example of how they are working with us. Because advocacy works in many different ways, through NGOs, through media, through others. But if you really want to get to President Obama or President Sarkozy or Chancellor Merkel, none of us will be able to pick up the phone and talk to them, or if we write a letter to them, that might be very kind of us, but they would never read it. But if they get the message from the right kind of people, then that is much, much more influential. And that's what we've been trying over the years, to kind of mobilize these kinds of people, sometimes celebrities, who really have that kind of access and help us in this effort. Do you think we get a video running?
Of a global fund. In fact, I called it a war chest. Quite a lot of people laughed it off, saying, there he goes again, dreaming. And I love dreams. It always starts with a dream.
Ask yourself, what do you need to live? Food? A home? A job? Your family? Love? And health? Without health, the others are not enough. It's one thing we all have in common.
If we are in the same boat, then a hole at one end of the boat puts all of us at risk.
Around the world, AIDS, tuberculosis, and malaria kill millions of people each year and handicap the development of entire nations. These diseases are not invincible, far from it. But to fight them, it takes commitment, the right strategies, money, and leadership.
The creation of the Global Fund was one of the kindest, most important things to happen to help improve people's lives. The treatment, whether it's for tuberculosis or AIDS or malaria, is saving lives, and that has a catalytic effect on allowing the community to take care of itself.
In 2002, the Global Fund to Fight AIDS, Tuberculosis and Malaria was founded to bring massive amounts of new funding to the fight against these three diseases.
There's truly an era prior to the Global Fund and an era after the Global Fund. When it comes to AIDS, in 2001, 2002, there was barely anyone on treatment in the developing world. Today, it is over 4 million people who access antiretroviral treatment, the life-saving therapy for AIDS.
2/3 of all international funding to fight TB and malaria, and nearly a quarter of the money used to fight AIDS, is now being channeled through the Global Fund.
I think it's fantastic to see how money provided by donors turns into real help, real medicine, and save the life of real people.
Through the Global Fund to fight AIDS, tuberculosis and malaria, over 3,500 lives are saved every day. That's 1.3 million people every year. We can win the fight against these diseases. It's just a matter of galvanizing the funding and getting the political will to achieve this.
Today, hundreds of thousands of health workers around the world are dedicating their work to saving lives with resources channeled through the Global Fund.
It's the countries that are in the driving seat. The countries decide on their programs, they decide on their budgets, they decide on how the money will be channeled. What we ask in return are the results.
The Global Fund is flexible. It doesn't make one-size-fits-all recommendations. The fund's focus on results has really helped drive progress towards the Millennium Development Goals.
While making sure that donor resources are being put to good use, the Global Fund is also strengthening ways in which partners can work together to fight diseases.
No one can fight an epidemic alone, nor the Ministry of Health or the public sector or the private sector or the civil society or the international organizations. When it comes to fighting an epidemic, everyone has to come together.
Well, the Global Fund is run very professionally. It sets big goals, it measures itself, it's constantly improving, and the injection of resources, expertise from businesses could help the Global Fund be even more ambitious.
All of us can be proud of what we have established, what we have done, but more importantly, be conscious of what still needs to be done.
There can be no let-up in the fight against AIDS, tuberculosis, and malaria. If we ease up, this disease will re-emerge. We either win this fight or we lose it. The success of the Global Fund is a test of global solidarity.
If we are to achieve the goal of eliminating transmission of the virus from mothers to children by 2015, there is still a lot of work that has to be done, but it is within our reach.
We can turn the tide on TB and ensuring that we've halted and begun to reverse the incidence of TB by providing access to treatment to those who need it. We also have the opportunity to end malaria deaths. Just like HIV/AIDS and TB, we have the tools needed to prevent and treat malaria. Death by a mosquito bite, no, not in the 21st century, we're not having that. These are very big and very bold and ambitious goals, but they're absolutely achievable.
You know what I mean? I can talk forever, but, you know, these people, that makes the difference. And, I mean, obviously, we are grateful that they agreed to be filmed for what they said, but that is a very powerful message that helps us, obviously, then to convince politicians. And that is a key element of this advocacy. When I designed our strategy for advocacy a couple of years ago together with my team, it's summarized in this slide, if you like. Because in the end, what we need to do is we need to reach a very small group of people. The leaders of the G8, the leaders of the richest nations, those who meet at the G8 summits and at other meetings, you know. And there are not many who can reach them directly. And that's why you know, what I call celebrity A. That's what you've just seen in the video. Those are all kind of A celebrities. There is the United Nations, represented by the Secretary General, very influential. There are very often heads of states and ministers from implementing countries, and we are increasingly, you know, working with them, and many have helped us this year in the lead up to the replenishment. But that is what political advocacy is all about. Let me then go very quickly through a number of slides. That is therefore what is also, hopefully tomorrow, in the final communique of the G8 summit in Canada, where the G8 leaders are also committing to continue their support for the Global Fund. So you will not be surprised if I'm quite pleased that this is in the final statement, if it remains there. And that will help us to run our replenishment this year. As I said, on October 5, all the donors will come together in New York and will then make their financial contributions for the Global Fund for the next 3 years. The chair of that conference is Secretary General Ban Ki-moon. Mr. Kofi Annan was the chair of the first 2 rounds, and Mr. Ban Ki-moon is the current chair, and we have been working for more than a year preparing all the donors so that they come prepared for that conference and pledge the resources that we need. A few words also to other kind of complementary efforts. We also need to increase contributions from what is called innovative finance and what is coming from the private sector. And I won't go into a lot of details so that we have a bit more time for discussion. I must say we had designed a scheme that converts debt into resources for health. And we have now just launched a new initiative together with Dow Jones that will mobilize resources from the investment sector. There will be an index, the Dow Jones Global Fund Index, where then, you know, private and corporate investors can invest. And both Dow Jones and a number of leading investment banks have agreed to share their fees then with the Global Fund so that we can turn that into resources that will be available in the fight against the diseases. Similarly, also, we are working very intensively with the private sector. Our flagship program is Product Red, where a number of well-known companies are producing certain products, and where part of the proceeds then also go to the Global Fund. You see the names here, the most prominent at the moment, because we currently have the Football World Cup going on in South Africa, and our most prominent partner there is Nike. And they are producing special laces and other products where part of the proceeds go to Africa and help us support our programs. So these are some of the innovative ideas that you need as well, because the public donors are always telling us that resources are limited and we have to see that we diversify the income and involve as many partners as possible. But also, again, for that, it applies what I mentioned before. You need a very good reputation, you need the confidence, you need the results, otherwise you will not get those partners. Let me now say a few words to conclude about the future directions in global health. There has been much complaint that the global health architecture over the last years has become too complex. And while we, I think, all appreciate the increase in the resources, it normally and naturally goes hand in hand with also an increase in the number of organizations and initiatives and partnerships. And I know that this is very confusing also for many who then have to implement all these resources. I do believe that now is the time to simplify the structure, to consolidate the efforts, and to think about viable, effective, and appropriate structure for the future. And I think this global health architecture for the future will have a number of important elements. First, let me talk a little bit about WHO, which obviously is the leading normative and technical agency. It has the constitutional mandate to be the directing and coordinating authority with respect to international health. And this includes establishing and maintaining effective relationships for us also with the United Nations, with specialist agencies, professional organizations, NGOs, and others. So the WHO obviously will play a critical role in the global health architecture and needs to be equipped to do so. But WHO is not a funding institution and has never been so. So I think that there should be a very clear division of labor. What is the role of WHO and what is the role of funding organizations like the Global Fund? Then also we have to improve the relationship between bilateral initiatives and multilateral initiatives. So there are obviously many bilateral partners here in the US, USAID and PEPFAR, but many others as well, and DFID and GTZ and CEDA and all these agencies, JICA and so on, that are present in your countries. I believe that in the future, it doesn't make much sense that every donor country will send its own missions and have its own little projects and so on. And therefore, we need a consolidation here, and we need also to think what is the comparative advantage of bilateral institutions and of multilateral institutions. The Global Fund, like Gavi, has no country presence, so we don't provide any technical support. We can't support countries in developing proposals, nor help you with the implementation. We are simply financing institutions. I believe that the best role for the bilateral partners is in the future to help particularly with the technical support, as they have the capacity on the ground that we don't have, but that we find a better division of labor between those two channels. And finally, also probably a consolidation of multilateral funding channels in health. So how will this future structure look like? There is now an increasing discussion about consolidating different funding sources and creating what some have called a Global Fund for Health-related MDGs. And Gorik, you have also sent a commentary together with others, to the Lancet that has been published asking for exactly that. But you've been in good company. There have been many others like Jeffrey Sachs and Mary Robinson and others who have been calling for this Global Fund for Health-related MDGs. And also the chair of the Global Fund board, Dr. Tedros, who will be with you tomorrow morning, has been an advocate for that and has been portrayed in the Lancet, where he has been arguing for such a consolidated global fund. So I do believe that this is a move for the future, that we will see over the next few years a very intensive discussion about this consolidation, how that should look like, and how we can concentrate these efforts, but also then broaden the mandate of such a fund so that we really can address all the important aspects of health. And finally, what is the effect of the current global economic and financial crisis? That might be also on many of your minds. What will happen in the future? We all know, we have an unprecedented crisis in many countries around the world. And the big question is, will we see a continuation of this? What happened over the last 20 years, an increase in the resources for health? Let me give you a couple of answers to that. I don't think we will see an increase of the resources like this. That would be unrealistic, and I can tell you that because I'm visiting many ministries around the world who tell me about their budgetary situation. Nevertheless, first, if you look at the G8 deliberations in Canada, and I gave you a few examples of that, you can see that health is still very high on the agenda, and that is a very positive sign. Secondly, you can see that politicians are now more interested in a broader health perspective. This year, the theme is maternal and child health, but it also extends to health systems, to neglected tropical diseases, and in the near future, we will also have to think about and address the non-communicable diseases, because that is the growing problem in many countries around the world, and we will have to think how we can address that and how we mobilize resources for that. So it will not remain limited to communicable diseases. Thirdly, the Global Fund is now firmly established. We are only 8 years old, but I do think that we have a significant level of confidence, by many partners around the world. So the Global Fund will not diminish in spite of the economic crisis. It is there to stay, and it is increasingly being discussed as a potential model for the broader approach for the future. Fourth, we have to do the groundwork and develop the right strategies so that resources will increase further as the global economy recovers. So some of what I've demonstrated to you, what we've established as an advocacy model, which I believe has been fairly successful over the next few years, we need then to apply to the broader health perspective also as the global economy will pick up again, that we can then also see a continuation of the increase in resources. And fifth, we need very strong joint advocacy to keep the momentum going. So in summary, I think this is a very, very critical year for global health. We have the Millennium Summit in September that will take very important decisions about the future of global health. We have then the replenishment meeting, and we have only 5 years left to achieve the health-related Millennium Development Goals. So I think now is the time to redouble our efforts and to make sure that we improve the health of people, that we achieve the results, and that we provide the feedback also to the political leaders that they continue their support. So in difficult economic times, with many of the poor countries hit the hardest, and that is what I often also say in the capitals of the rich countries when they tell me that the budgets are under constraints. I say, yes, you're affected by the economic crisis, but many poor countries are even more affected. And they often do take that into account. So in this situation, it is particularly important to ensure that the health inequities between the rich and the poor countries do not widen further. In 2010 and the years to come, we need to continue to scale up AIDS, TB, and malaria programs, at least at the same pace as the recent years, but also address increasingly the other major health problems. In international development, particularly in health, the first decade of this century was dominated by hope and optimism. We must ensure that the second decade is not infused with cynicism from broken promises, but builds the foundations for a bright future. I thank you very much.
Thank you, Christoph, for that presentation. Maybe we could take a few questions from the group. Dr. Swart.
Thank you for the presentation, which is, again has been very good and very educative. We are happy that the fund is no more as vertical as it used to be when it first started. And we're appreciative of that. The problem we still have is one does not know how much of that can really go into health systems strengthening. Mm-hmm. I know you've said it's flexible, but the focus is still on those 3 diseases. And in writing our proposals, sometimes we are really constrained. If I add so much of other areas that are equally important, that will make sure that we are dealing with the country's health needs. You don't know how far you'll go. And I don't know how you are, the fund, the board is going to address this.
Yeah. I know that is a key question, the health system support. But I think it has already happened in many countries that a lot of the resources have gone into what you would call health system strengthening, not just into buying drugs or bed nets and so on. We estimate that about 35% of the total resources went into the health workforce, as you discussed earlier today, the training, salaries, and so on, but also health infrastructure, management systems, M&E systems, and so on. And I think that is the kind of trend also for the future. But basically, my message is the Global Fund is yours, in a sense. You might not always feel like that. You think the Global Fund is this organization that is sitting in Geneva, and you don't know what can we do, how can we apply, what can we put in there. But also, you're sitting on our board. The board is constantly trying to kind of, respond to those questions. Obviously, there is no better person to address exactly that question than Minister Tedros, who will be with you tomorrow, because he's the chair of the board of the Global Fund. Minister Tedros, what he will probably tell you, what he has told, us and others many times, is he used a lot the flexibility of the Global Fund in Ethiopia and didn't feel kind of limited by, yes, he's addressing the 3 diseases, but, at the same time, he used a lot of the resources to train community health workers, always telling us, yes, these health workers, they, provide treatment, they also help to distribute mosquito nets, but they do many other things as well. And the Global Fund is very happy with that. I think there are quite a few of you from Ethiopia here who know that very well, better than I do. But I mean, he always says, and I helped to build a lot of health centers, in the rural areas. And guess what? They are not just addressing the 3 diseases. They are, strengthening the health system overall. if the chair of our board could do that, many others can do that as well. So my message is absolutely. I think the direction of the future is, more investment in the health systems more broadly. We use AIDS, tuberculosis, and malaria as the entry point for now. We might discussing, moving more into maternal and child health in the future, and you will have a fund that should be there to address your priorities, as you define them. So that's how I see the direction of the fund, and I think you will find a lot of sympathy for that in the board of the fund. Mike, you're...
You got it.
Okay, I will ask a couple of questions. The first question is, where the MDG target here is left with only 5 years to go. Would you give us a glimpse of the scenario beyond 2015?
Yeah.
The other again is the Global Fund functions, programs, and strategies. Will there be any change now with the Global Health Initiative coming into the picture?
Yeah. So first, what will happen after 2015? It's a little bit early to say, of course. And there is a slight danger in that. We'll have a lot of discussion on that at the upcoming MDG summit. What we don't want to allow is that, the donor countries already say, we can't reach the MDGs, so it's coming close now, but as we can't achieve them, let's redefine the targets and so on. That's not what we would like to see. We want to say, no, keep up the momentum. We want to achieve the MDGs, and then we can think what the next targets are. Because, there are many other important issues that are not addressed in the MDGs, and obviously we will have to look beyond the MDGs. I mentioned, for example, the non-communicable diseases. They're not mentioned in the MDGs at all, right? So we will have to start to think, okay, what's the next phase? What are the next targets that we have to address? But we have to be careful not to let anybody off the hook, right? To prematurely say, we can't reach it anymore. No, let's achieve those and then set new targets that you should define in your countries, what are the next targets that we want to do in health, obviously also in education and other very important issues. But in health, we need then to think, what do we do beyond? And the second question, excuse me, was? The functions, programs, and strategies of the Global Fund change with now the Global... Yeah, with the Global Health Initiative, yes. I don't think it will change. The Global Health Initiative has been launched, over the last year, let's say. And just last week, the priority countries were announced. So it's kind of early stage. And also, if you look at the budgetary allocation, it's not that much money yet that is available for the Global Health Initiative. What we are saying from the Global Fund is, let's work together, let's partner with the Global Health Initiative, and look at the Global Fund also as a key partner for the US to achieve the targets that you will have seen in the Global Health Initiative. And it's so that it's not just a US initiative, the whole world has to work together to achieve that. It cannot be achieved by the US alone, and definitely not with the kind of budget that has been allocated so far. So the Global Fund is a possibility also to expand the Global Health Initiative to get the support of many other countries, of the private sector and so on, and we would be most happy to work with the Global Health Initiative to reach those targets as they've been defined. So I think, it's still early days, but certainly we've had quite a few contacts already with our US colleagues, so we want to see a very close partnership between the Global Health Initiative and the Global Fund.
Thank you for your great talk. My question is not Global Fund related. It's more of a process issue. I want to learn from your experience about this process. During our stay here, we've been talking about leadership and accommodating dissent. And one of the issues we discussed was the fact that sometimes conclusions of meetings are written before the meeting begins.
Oh, you mean what I said about the Canadian G8, right? Sorry about that, yeah.
I just want you to share your experience on that front.
Yeah. About drafting statements beforehand.
And I mean, do you get people dissenting, and how do you manage that process?
It's a very good question. I think for the G8, there's no other way but to prepare those statements long beforehand, because, you know, these leaders come together for 24 hours, you know, and then they move on. So they have no time to negotiate that. So their teams, you know, have been working for a year to draft those statements. And that's the only way how you get an agreement at that level. But that shouldn't be a model for every important decision, right? And actually, the Global Fund board is a very good example for that. Because yes, we in the Secretariat, you know, we draft decision points and prepare decisions as well. I mean, we can't just, you know, come to the board and then think, what are we doing today? And, you know, what kind of language will we put in there? But we very rarely come out with exactly the same language as the language was when we went in. So there are real serious discussions in the Global Fund board. Some of you might be familiar with that. Actually, every year when we launch a new round, there are intensive, you know, discussions about, shall we launch, shall we not, under what conditions, how will we prioritize? So that would be an example where you go into such a meeting, you have an idea, you have a kind of draft, but there's a real negotiation, sometimes until the last hour, and then you come out with a compromise. And I actually like that, because, you know, you need the spirit also of compromise, that people who are coming from very different perspectives in the end come together and can find a consensus. And that is the way what you can achieve with a board, as I described it, where people have the equitable, you know, right, not just to speak, everybody can speak, but to make decisions. Because in the end, the chair knows, you know, I need a 2/3 majority in both groups, so that forces them to work together, and they do work on these decisions and don't come in with, you know, pre-cooked conclusions, if you like.
Normally, I would be the one asking you about mental health, but I like
You are
your...
most welcome to do that.
No, but I liked your answer about using the 3 diseases as an entry point. I really like that and appreciate that very much. But question is this. Over the years, we see different emphases in fighting illness. Take malaria. It used to be that we looked at the environment and sprayed the environment and all of that. And then we put some emphasis on the drugs, and now we put emphasis on the bed nets. Mm-hmm. And I just wonder what you think about the shifting emphasis, and if at some point, who determines this shift, and where is the balance in, you know, in the effectiveness, because something is lost always when you move like that. Just,
I mean, so if we take the example of malaria, but we could take, you know, other diseases as well. The decision on what to support, what is the kind of strategy, in a sense, to combat a disease, is not made by the Global Fund, right? That's not our expertise, and we don't want to assume that role. That is exactly what I see as the primary role of the World Health Organization. First of all, to kind of develop some of those policy strategies. But then it has to be adapted to the country level, because in the end, it's you who know what is working best in your country. And whether you want to focus on bed nets, or whether you want to focus on indoor residual spraying, you want to focus on treatment or on other, you know, vector control policies and so on. So, you know, WHO provides the framework, the countries decide and put that into their proposal, and the Global Fund, our technical review panel is only there to say, are those proposals according to the internationally established guidelines or not? And then, you know, is the capacity there to implement that? Is it a sound proposal? Then it will be approved. So we don't get, you know, engaged in that. So that's the answer to the malaria question, but I'm sorry you didn't ask me about mental health if you wanted to, because it's part of what I meant, you know, we have to think beyond now, right? I mean, I just mentioned the non-communicable diseases in general, but I think we all are aware, you know, what the what the current burden of disease is. You will know what the burden of disease is in your countries. We know about the projections for the future. Mental health is very prominent, you know, among the burden of diseases for many countries. Depression, for example. We could talk about accidents and injuries as a major cause for morbidity, mortality. Other diseases are increasing in importance. So I think we need to take the broader view, and you need to define, in a sense, you know, what are the major health problems that you are struggling with, and where you would say, this is what we can do and finance domestically, and that's always the kind of foundation, that's the basis. But then what are the elements that we cannot, with the best of our efforts, in a sense, you know, address, but where we believe, coming back to the notion of health as a human right, that we should provide those services, and that should, you know, determine the services of the future.
Yes, Talia.
Thank you so much. Thank you so much. This was quite revealing, very interesting. I wondered about the compliance and accountability side,
Yep.
which has been in the news of late, and whether or not the trend and the satisfaction of the fund itself with the performance taken as a whole over the years has been high or low or medium.
I personally, also because, you know, I've been on the implementing side, have been honestly impressed by the performance of the programs that we support, you know, globally. If you take all the 600 programs and, you know, we calculate the average of the targets they achieve, the number is, on average, all the programs achieve 94% of their targets. I think this is absolutely exceptional. And this has nothing to do with the Global Fund. This is you who are achieving those results, right? We are just providing the money. But that is quite exceptional in terms of development finance. We know from many institutions, if you achieve, some would say 50%, if you achieve 60%, you would say fantastic. But more than 90% of the targets really achieved and verified, that is quite exceptional, which obviously means that, you know, some targets are overachieved. You know, it can be bed net distribution, it can be TB case detection. They might achieve 120, 130% of the target. They go beyond, and others lag a little bit behind. But overall, the performance is really very, very good. And we measure that very carefully, and we report regularly on that. So I think that is quite encouraging, actually.
Maybe one or two more questions or comments. Yes, KP.
I just had thanks for a great presentation. I just had a quick question around complexity, which you mentioned. I watched a program recently that was aired here in the U.S. That was an interview of Bill and Melinda Gates and Soros. And they're doing some really good work trying to engage other ultra-wealthy individuals to basically use their wealth for human welfare globally. But at the same time, as you've described, I mean, more is good, but with this complexity also has its challenges. Kind of beyond governance, which we see you do well within the Global Fund, that's within your control. With these external players that have their own boards and agendas, how can that be managed?
Yeah, excellent question, thank you. Yes, I read that obviously with great interest, that, you know, Bill and Melinda Gates and Warren Buffett encouraged other billionaires to kind of be more generous and join them in their effort, and I think we all applaud that. But you're quite right. I mean, you know, what would happen if they do so? I think not a negative, but a less positive outcome would be that every rich billionaire wants to start their own little program, right? And that can easily happen because they want their name attached to a program here and there, and I think that would lead to even more kind of complexity and more, you know, different programs and reporting lines and all that. And I don't think that would be a very good outcome. We have a very good and constructive relationship with the Bill and Melinda Gates Foundation, so there's no overlap basically whatsoever, right? They partly support the Global Fund directly. They give us $100 million a year, And then they concentrate on areas that the Global Fund does not cover. I mean, in particular, they invest in research. For example, malaria vaccine, AIDS vaccine, and all that. And that's great because that's not what we do. That's what, they are much better suited to do so. I believe if, they succeed and persuade more of these billionaires to give, I think they would be well advised to join these other initiatives, not to create new ones, right? But either if they want to support programs on AIDS, TB, and malaria, give the money to the Global Fund. If they want to support vaccines, give it to Gavi. If you want to support research, give it to the Gates Foundation. That's what Warren Buffett has done, which is quite amazing. I mean, he gave away a lot of his wealth and said, I give it to Bill and Melinda because they know what they're doing. Another example is Carlos Slim. At the moment, I understand the richest man in the world is overtaking Bill Gates, the Mexican businessman. He joined with Bill Gates in creating some programs in Central America. And I think also that was good, that he didn't try to do something on his own, but say, okay, I join forces with those who exist. That's what I meant when I talked a little bit about consolidation. Not, everybody creating another, little program, but let's bring it together. That's also what we are trying with these companies, like Product Red. I mean, you saw Nike, Starbucks, Dell, Microsoft, Apple. They could all do their own kind of programs here or there. Would that help? Probably not. It's much better to kind of channel that through the existing channels, and that's part of the simplification.
Great. Well, Christoph, I want to make sure that you and Lauren make your flight today.
We appreciate that.
So thank you so much for your time with us today.